My disclosures have not changed over the morning, so I will start with a case presentation that I always show when I start talking about sacral pelvic fixation options, and it's really a public service announcement for why you should utilize it when you need it. This is a 55-year-old female who simply had an L5S1 spondylolisthesis and underwent a posterior reconstruction. She did well briefly and then started having increasing back pain and significantly severe malalignment. And if you look at that x-ray there, her lateral x-ray is really abnormal. When you see a person that looks like this, it's very obvious that something's wrong. When you look at it, right, she's got an elevated SVA, but when the back of the sacrum is here, and if you draw a line up and nothing ever touches it again, right, it's totally, her whole body's in front of it. That's a significant problem. And if you look at it, she's got a lot of lumbar lordosis. So why does she have that? Because she had screws stopped at S1, probably not great bone quality, a little bit of a high demand construct, and she fractured below that. So when she fractured below that, they simply said, well, let's, put you in a brace, gave her a leg extension, put her on, limited activity for a while, and eventually this fracture heals, but it heals in kyphosis. And when we talk about pelvic incidence, if you think about pelvic incidence, it's supposed to be a fixed parameter, right? Except if you fracture your sacrum, you change that angulation of your S1 end plate, and you actually increase your pelvic incidence, and now create a mismatch that is really abnormal. So when you think about how are you going to fix this, right? You think about, well, what's her bone quality? How am I going to get this back aligned, and what am I going to do for fixation, which is obviously going to be a challenge because we're failing down at the bottom. So the problem is the sacrum. It's not a great fixation point. You cannot fill the sacral pedicle, right? You heard yesterday you want to get the biggest screw to fill the pedicle and engage the cortical bone. The sacrum is, the S1 pedicle is simply too wide to do that, right? It's much wider than it is tall. It's impossible. What is going on here? Dial in these little screws. It's impossible to fill that and get good fixation. And it's mostly cancellous bone, right? If you look at these various cuts here, you can see it's all this cancellous bone. There's not a lot of cortical bone to grab. And if you're trying to put a screw in there, particularly if you put a unicortical screw in there, it's just swimming around in there. It's not a very good fixation point at all. So, and the sacrum at the bottom of your construct sees a lot of forces. So every time somebody leans forward, every time somebody gets up to get out of a chair, they lean forward, they throw their weight forward even when you've got them fixated, and they're going to put cantilever forces on that bottom of that construct, and that's going to want to plow those screws through that sacrum. So no matter how strong they are, if you keep putting, force on it, unless that bone has healed and healed relatively quickly, you're going to end up getting loosening or plowing, or something bad's going to happen. So when we talk about sacral fixation, right, we've got S1 pedicle screws, which we all should know how to do, and then a whole bunch of other things, which, some good, some less good, and some are going to be presented for more historical basis than anything. So if you think about fixation in the sacrum, first thing is to get good S1 screws. That's step one in any sort of fixation to sacrum and pelvis. So you want a good S1 pedicle screw. I do not know why it's doing that, sorry. And there's good data that shows like bicortical fixation is mandatory, right? You got to get through the front of the bone. The tricortical fixation, which is what you see here, that screw that's getting that sacral promontory where the end plate and the front of the sacrum is there, is a part of that where you get improved insertional torque if you get that tricortical fixation. So that's what everybody should be trying to do. The same data here, right? If you see that insertional torque, is it this cord? Sorry, I swear I'm not touching it. So you want, this is showing that same data where you see this insertional torque in the tricortical screw is much better than bicortical screws, and unicortical is terrible. So a good S1 screw placement, that's a key. So you want to be on that inferior lateral aspect of that L5S1 joint. I tell our residents that it's just like a lumbar screw, except the sacroiliac is the TP and the facet joint's the facet. And you kind of want to be at that bottom edge of it there. You start a little lower in the sacrum than you do in the normal lumbar pedicle because you're not trying to parallel that end plate. You're trying to go from low to high to get the longest, biggest screw you can to angle right for that upper corner of that. It's usually 20 to 30 degrees medialized, and you want to get all the way through that anterior cortex. There's a fluoro shot that shows that with a pedicle probe down right to that promontory. You can place this with floor, you can place this with nav, you can place this freehand. I place my screws freehand. I take a Lenke probe, and instead of having the curve, which you normally do, curved medially, so you bounce out of that medial pedicle, I rotate it 90 degrees, so I'm bouncing off the top of, that S1 end plate. So I'm going to feel down that S1 end plate and curve down until I get to that promontory. And that works really well. Actually, when I place screws freehand, I tend to have a better looking screw at the end than if I fluoro it or nav it or anything else. So I've been freehanding them for now several years. You want to measure that and make sure you get that to go through. And I generally want to be 5-ish millimeters through the front. So if I measure 46, I put in a 50, right? If I measure 48, I put in a 50. I don't want to be way long and sticking out there because you get into trouble that way too. So again, how do these fail? They fail with screws can break, screws can pull out, and they plow. That's what you see a lot. They loosen and they start to plow through there. And once they start to loosen in there, you're losing your one good fixation point in your sacrum. All the other ones aren't very good. And you've got a problem in trying to reconstruct that. So here's somebody that's happened. 55-year-old obese female came to me. She had a lumbosacral fusion, and this is what her CT scan looks like, right? She's got these big halo S1 screws, and she's got a big iliac crest graft. So not a lot of fixation options. So she ends up with a little bit of a complex construct here, a little bit of an Alar screw, trying to fixate something there, and then some paired iliacs with a Transiliac bar, just trying to get some type of salvage fixation, which fortunately we got away with. So everything else we're going to talk about is adjunctive fixation. It is to offload your S1 screws. You hear people talk about things where they start skipping S1 screws and putting in other things. Don't do it, right? All of these techniques are to offload your S1 screws, which are your primary fixation point. If you can't get them, right, you're trying to salvage and cobble something together like I just showed you in that case. But don't skip them intentionally for rod run or anything else. You need S1 screws, and everything else backs it up. Here's a case that I got called on. This is a physician who was in the hospital. I got called. He had degenerative disease and with a T10 to S1 with pliffs at the bottom. And they called me. He'd been in the hospital for weeks, hadn't been up, hadn't done very much. He had surgery, didn't do very well, got an early infection, washouts, plastics flap. And now he was getting upset and wanted a second opinion, so I get called to go see him. And you can tell all he had was these supine x-rays. That's all they had for him. And you could tell right away he's got just S1 screws, and they're poorly placed, right? They're not medialized. They're just sticking through. It's a long segment construct. He's a bigger guy. So we get a CT scan, and I go examine him, and he's got foot drops, which nobody knew about. And he's got cages that are now in his spinal canal. He's still in the hospital from his index surgery. He's already loosened his screws, and he's already got cages spitting out. My recommendation is that it needs to be revised, and you need to, revise that, get pelvic fixation, and they elected to do that. I was not involved in the revision. They pulled the S1 screws, put iliac screws in, and pulled that one cage out. Nothing else. So of course, right, he's already seeing a lot of forces at that bottom. He's got nothing at S1. He's just got iliac screws, which aren't a good primary fixation point, and they loosen and they fall apart. Then he finally comes to see me in follow-up, and we do an anterior. So he's been infected, everything's a mess, so we do an anterior and then revise him down to iliacs. I get S1 screws in just to be a little different trajectory, and he goes on to successfully heal that and fuse that. And see, I use a mesh cage because of the infection. But finally, after a lot of surgery, we get him to heal this, and you can see he's now solidly fused across the bottom there. All of that could have been avoided with the right surgery up front. So indications for the adjunctive fixation: long segment constructs, anything from L2 or above going down to the sacrum gets adjunctive fixation. Osteoporosis, spondylolisthesis, high demand constructs. If you're correcting somebody a lot and stopping at S1, I don't care if it's a 2-level case, think about some adjunctive fixation because you're adding a lot of force into those bottom screws. So things you can use: S2 pedicle screws, not very good. It's short, there's not much there. If that's all you have, that's all you have. You can get something, but it only gives you about 15 to 20% decrease in that screw strain on your S1. Sacral Alar screws. I think Kojo is going to show you in the lab a couple of different ways to put Alar screws. The new Alar-Iliac screw is something I'm going to talk about differently. This is a screw that goes up. Let's see. But it adds 20 to 30% cantilever resistance, so it works, but it's not as good as something like an iliac screw. This is the old Jackson intrasacral rod where they actually used to run the rod down in the sacrum. They used to do Galveston, we put in the Ilium, or Jackson where you go into the sacrum. I don't know anybody that uses that anymore. It's a tricky technique, though. The problem with that is that that would just work its way through the bone and they'd lose correction. I've taken them out several times where it just plows up through that bone because there's just not a lot to hold it there. So then iliac, you can do iliac screws, which are common, which we'll show in the lab. Galveston fixation, which again is more for historical. Transiliac screws and the new sacral Alar-Iliac screws. So why do we use pelvic fixation? Because it's good at offloading those sacral screws. Improve your fusion rate, decrease your S1 strain by over 70%, but there's some complication rates. And if you look at historical complication rates, you got to remember it's exactly that. Techniques change, implants get better, we get better with techniques over time. People used to have gluteal pain, they'd have to remove those implants at times. I can tell you, I have hundreds of patients walking around with iliac screws in, and I've only removed them twice for pain. 2 patients that I've had to take screws out. It's not very common, with at least the way I do it, but I'm really careful to get it really low profile underneath the bone so they can't feel it. They never sit on it, they don't feel it at all, and I think that makes a difference. This is graphically why it's good. These are the iliac screws, and it's how much you're offloading your S1 screws much better than all the other techniques. And the reason is it gets in front of the axis of rotation of the sacrum. These long iliac screws get in front of that axis of rotation, so you get much better resistance to that cantilever force you're putting on those S1 screws. So how do you put those in? You can do it a couple of different ways. A lot of people cut a notch out of the bone. Some people come just medially to that bone. But anyway, it's kind of PSIS to ASIS essentially, running over the sciatic notch. The sciatic notch is really strong, thick cortical bone. So if you put the screw directly above it, and if the force is going to be this cantilevering against it, you've got a really good, strong bone you're sort of levering up against, and that's why they work really well for that. Again, you see some pictures of it there. So if you place an iliac screw, you can still take an iliac crest bone graft. You can go up above that and take a more traditional graft. I tend to harvest iliac crest bone now in all of my deformity patients. So I go in and I cut a notch out of the ilium. I just get a pituitary and reach up cephalad away from the caudal trajectory of the iliac screw. And I get enough bone at least to use it L5S1 and to fill. I usually do a T-lift at 5.1, maybe 4.5 to fill those discs so I don't put biologics or anything in the disc space. I use just autogenous iliac crest bone, which I think is great for fusion of those. I got a few pictures of that, but I'll skip these in the interest of time, and we'll just go over it in the lab. So classic kind of patient, a degenerative lumbar curvature guy with a kind of big belly there. Iliac screws, offset connectors. That's my go-to technique. So the S2 Alar-Iliac, that's a little bit of a newer technique. It's been now around for many years. People are utilizing them. Started at Hopkins, and they started using this in neuromuscular kids, which it works really well for. It's a nice screw for that, and then it has spread to use in adults. It's different using it in a kid versus using an adult in terms of what I think your outcome is potentially. But it's certainly a useful technique and one definitely to have in your armamentarium. That screw goes, instead of going right into the ilium, it starts in the sacrum, crosses across the sacroiliac joint, and then back into the pelvis. It also sits above that sciatic notch, and it also offloads those S1 screws, and it's biomechanically similar. You can see some pictures of it there. So how is that one placed? That is placed between the S1 and S2 posterior foramen. It's a little bit closer to S1 than it is to S2. And I do it just on the lateral edge of that foramen. It's about 10 degrees caudal, and I say about 30 degrees lateral from like the horizontal. So it's really angled out to do that. And you pass a probe through, and you will feel, you get through your initial cortex, but you'll feel a pop and a pop as you go through the 2 sides of the sacroiliac joint and then back into the pelvis. The trick here is to not break out anteriorly. So that's the risk that doesn't really exist in a traditional iliac screw, that you can break out anteriorly and cause some trouble. And you can see a picture of it there going across, trying to angle right above, again, that sciatic notch. You want to put a big screw, you want to put a long screw when you place these. So it can be done freehand, it can be done with nav, it can be done with fluoroscopy. So a lot of people use fluoroscopy, use an AP view to make sure you're above the sciatic notch. This is what's called a pelvic inlet view to make sure you're not breaking out anteriorly. It can be really nice. And you can use the traditional teardrop view that people use for iliac screws, trying to make sure you can see that teardrop on that x-ray and put it right down the middle of that once you get into the pelvis. So if you look at the biomechanics, it's similar to an iliac screw. It's no better, no worse. This study looked at a 90 millimeter iliac screw with offset connectors versus a 65 versus an 80 versus what they call the quadricortical S2AI screw, which is essentially going, the first cortex is where you make your breach in the sacrum. 2 and 3 are as you go through the SI joint. And the third is they actually drove it out through the pelvis again, out into soft tissue. Didn't help at all. So all of those were equivalent. So you didn't get a big difference in any of those screws. So the key is you want to just get far enough into the pelvis that you're in front of that axis of rotation. This study looked at comparing S2AI versus traditional iliac and found that the S2AI was better. They had less implant loosening, 18.6% in the traditional versus 0% in the S2AI, less breakage, less pain, and no revisions. So like everything, when you look at literature, you always have to sort of read the fine print a little bit and think about what they're doing. So they had, no revisions in these, and then they show an X-ray. So we got 2 broken S2AI screws and broken S1 screws. It's a clear pseudoarthrosis. I don't know if the person died, but they didn't get revised according to their study, which I don't quite understand unless there's some sort of bias there. It clearly failed, so it's not a perfect solution. Here's one of mine. S2AI screws. And if you see an iliac screw break, it breaks right underneath that screw head. If you have to revise that, you can go just take the head off and leave the screw in the bone. It doesn't do anything. Nothing's moving in there. There's no problem. This screw breaks here. It breaks right at that SI joint. If that person has pain there, that's my big concern always. How do I get that out of there now? That's a bear to go and get that screw out of there if it's a problem. Fortunately, in this one, so far it's not. And people say they don't break very much, or they shouldn't break, but this screw exists right here. And what does this screw tell you? Does anybody have an idea what that screw? Right, smooth shanked. Why do you think it is? So it's smooth shanked because there's no inner and outer diameter, right? Now it's all the outer diameter. It's thicker and stronger because something was breaking, right? You don't take your screw and have to augment it and make it stronger and change it unless it's breaking somewhere, right? So it's thicker here, trying to prevent breakage. So if they say, it doesn't break, well, it did at some point because you totally redesigned your screw. Good if it doesn't break anymore, but you have to think through every time you see that. Here's a study showing the opposite. So iliac screw was better than the S2AI screw. The moral of the story here is it's more technique dependent probably than what you're placing. It's what works best for you and what you do well and what you get the best outcomes with. I don't think one is necessarily better than the other, and I kind of pick and choose and use both, but I'm more of a traditional iliac guy, so I've got my own bias. Here's a study, this was out of Hopkins, where they started this process, looking at their revision rates S2AI versus iliac, and it looks way better for S2AI. But you got to ask what this patient population was, where you got a 48% revision rate on your iliac screw with a 44% infection rate, right? These are, right, that's not a normal population, right? Those are big sacrectomies, tumors, also, like that's got to be crazy stuff. So it's not an apples to apples comparison. And then they did this study showing prominence. And if you place your iliac screws where it shows there in red, you're going to have problems with prominence. That's not where you should put your screws. That's where people traditionally had problems with it because they're sitting, as soon as you sit down, it's right up under your skin. If you bury that screw within the bone, it's no more prominent than an S2AI is. But you can see in that study how you could have a problem if that's where you placed your iliac screws. Again, technique dependent more than, or operator technique dependent more than like actual surgical, technique. So, pros and cons of S2AI: strong fixation equal to iliac screws. You don't have to use the offset connectors for MIS. I can see that being really useful if you're trying to run something there and get it to run within that rod. It's nice to be able to run your rod directly in those screws and not have to fiddle with offset connectors. Absolutely. Long-term durability, I think it's still, jury's still out a little bit. The bigger, stronger screws are hopefully better and going to not have breakage, because I do fear breakage at that SI joint. For me, they're harder to place than iliac screws. Is that risk of breaking anterior is a little more fiddly and cumbersome. Not significant. There's a learning curve like anything, that it's not too difficult, but a traditional iliac screw is a really easy screw to place. Again, just a few more examples here of failure. Here's how I tend to use S2I screws in mine. This is somebody that came in, long segment construct, totally haloed out at the bottom, pseudoed, not much fixation. I put in a combination technique where I'll put an S2AI and a traditional iliac and then connect them up to try and get some type of fixation through that type of scenario. This is a 72-year-old, had previous surgery. Again, T10 through S1. And if you look, T10 to S1, no inner body at 5'1", and just S1 screws that weren't bicortical. Of course, that's going to fail. You're setting that up for failure. That person one of those needed some kind of good inner body, maybe anterior with some screws or plate, or posterior with iliac fixation or S2AI, something to offset that. But he didn't have them. He failed at the top and the bottom. And since he was haloing things out there, I did a little bit of a combination technique there as well, where I put an S2AI and actually used that to run a third rod off of, and then traditional iliacs and an ALIF on that to try and salvage fusion. Again, combination technique for a person that had a giant sacral tumor, not a lot of bone to fixate to, just trying to get bone in, or some fixation into bone where we needed it. Pelvic ring reconstruction, this is more of a tumor technique. Now we tend to do it like this. Historically, back when I was in training, I was with Steve Andre, and he would do some of these, which was really kind of crazy. This is a pelvic ring reconstruction for sacral osteotomy, which we'll talk about at the end here. Here's one of a Trans-iliac bar actually through and through the pelvis, going through a cage when there's no sacrum after sacrectomy. That's that going through. You can see the rod going out like through and through. He'd actually drive it through, put a connector on here, and pull it all the way through, and then put a connector on there. It was crazy to see. But again, now we just kind of run extra screws and run a rod across there, which is a lot easier than that. So again, here's the case presentation, that S1, S2 fracture. We ended up doing a sacral osteotomy, so like essentially a 3-column osteotomy through the sacrum, disconnecting the sacroiliac and rotating the pelvis to reduce the pelvic incidence as opposed to adding more lordosis. And you can see the significant change that makes in overall alignment, where she was dramatically malaligned by reducing the pelvic incidence, how powerful that is in terms of alignment. Another few examples, another long segment construct stopping a sacrum failed. They let the fracture heal. Did another osteotomy there. You can see the pre and post. Another one. This is a mild meningocele patient, which made it really tricky. And you can see the implants get really crowded. I got not as much correction as I wanted to because I ran out of room. Everything touched. All the metal touched, and once it touches, there's no more compression that can be had. And you can see all that there, how crowded that can be. It's a little bit of technically challenging procedure. So in conclusion, you need to know the adjunctive techniques. You need to do traditional iliac and S2AI, at least walk away knowing those. Know when to use them. It's really important to offload those S1 screws. Prevention of that failure up front is a lot easier than having to go back and salvage it at the end. So thank you.